Hello, and welcome to the Transforming Surgical Services, Strategies for Enhancing Surgeon Engagement and Optimizing Block Time and Robot Efficiency. Thank you so much for joining us today. Before we get started, I would like to go over a few housekeeping items. You can submit any questions throughout today's session in the Q&A box on your dashboard. Today's session is being recorded and will be available after the event. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. Lastly, you'll also find a few other engagement tools on your dashboard. Be sure to check out our resource section and fill out our event survey. At this time, it is now my pleasure to begin today's program by introducing today's speaker, Dr. Brian Cann, Chair of the Block Committee and Department Chair, Colon and Rectal Surgeon at Ochsner Medical Center. Thank you so much for being here, Dr. Cann. I'll now turn the floor over to you.
All right. So thanks. I appreciate the opportunity to talk to you guys. And what I'm going to share with you is our experiences with IQ, the scheduling platform, and sort of implementing it here at Ochsner. Just to give a brief introduction, we'll talk about some of the challenges that we had prior to implementing IQ. We'll talk about some of the new processes we put in place and solutions, and kind of highlight some of the key successes by looking at metrics and our outcomes. And then we'll have time for questions at the end. So just a little bit about Ochsner. Ochsner Health is a nonprofit academic multi-specialty system. We employ over 4,600 employed and affiliated physicians, over 90 medical specialties and subspecialties. Ochsner Health operates 47 hospitals and 370 healthcare centers and urgent care centers throughout the Gulf South, throughout Louisiana, Mississippi, and Alabama. And we also are a major training center as well, with 30 ACGME sponsored fellowships and residencies. Ochsner Medical Center is the flagship hospital of Ochsner Health. We're a close to 800 bed hospital located just outside of New Orleans in Southeast Louisiana. We operate 3 centers of excellence here: the Cancer Institute, the Transplant Institute, and the Heart and Vascular Institute, and we are a magnet recognized facility. We have 32 total ORs, 26 in our main OR. And then we have an additional 6 operating rooms downstairs in our sort of ambulatory care / pediatric surgery center. So that's what we're working with in terms of ORs. So some of the challenges that we had prior to IQ, I took over running the block committee. I arrived at Ochsner in 2015 and took over as chair of the block committee the following year. And when I took over as chair of the block committee, it's kind of in shambles. Our block utilization was less than 50%. We really did not have good definitions of what we considered adequate utilization. Our block structure was very haphazard, and the data that we were collecting was really unreliable. The system that we were using to capture our data we thought was okay, but as we kind of went through the process of trying to figure things out, we realized how bad the data really was. So we really didn't have good data in terms of our OR utilization, and to be honest, no one really trusted the data. The other thing that was a problem was we really had very little predictability in our OR schedule. We had very little PRN or time to add cases on outside the elective schedule. They would just get tacked on to the end of the day. Surgeons would just book cases whenever they wanted to, and then they would get put on the add-on schedule, and we were starting elective cases at 8, 9, 10 o'clock at night. It really was a dissatisfier for the surgeons, for the patients, for the staff. So with very little proactive release of unused time and very limited visibility into available OR time that we did have, and the very little actual OR time that we had, it made things difficult. The other thing is, as we became more active in robotic surgery, we really did not have well-defined robotic block. Robotic block was sort of separate from OR block, which made it even more complicated and confusing. You had to have available OR time, and then there had to be available robotic time within your available OR time in order to book a robotic case. So it became very cumbersome for robotic surgeons to get cases scheduled easily. And then lastly, because we had no trust in the data, really, there was very little surgeon engagement with trying to proactively manage the schedule, and everybody just it was a free for all. So these are some of the problems that we were faced with dealing with prior to implementing IQ. So just as a little bit of background, also, when COVID happened and our OR shut down, we really took a long look at how we were going to reopen and how we were going to operationalize things. And so we started obviously with a limited number of blocks, and we had just kind of started to get the ball rolling in terms of being a little bit more efficient. And then in the summer of 2021, Hurricane Ida hit the Gulf South, and we were again shut down for a period of a couple months for anything other than emergency type care. So again, we basically were back to square one. We lost a lot of OR staff who were displaced by the storm, didn't have homes. So again, as we started to ramp back up, we had limited resources, we had limited staff, we had a huge backlog of cases to get done. So all in all, it was a real struggle to kind of figure things out. So that's when we decided to work with the folks at Leantas and implement IQ. So part of that first process for us was shifting our block schedule. Previously, our block schedule was done based on service lines and departments. So we didn't have individual surgeon blocks. So for instance, I'm a colorectal surgeon. So colorectal surgery had, 2 blocks on Monday, a block on Tuesday, 2 blocks on Wednesday. And it was up to the chair to decide how to divvy up that time. And some departments were really good at it, and some departments, quite honestly, were not very good at it. And a lot of it kind of hinged on how engaged and interested the chairman was, to be honest with you, because there were times where I would go to the chair of a department with their metrics, and they would clue. I didn't even know what days they had block time, quite honestly. So without any engagement in that regard, it was difficult. The other thing is you lose, by having group blocks as opposed to individual blocks, you lose a lot of the granularity of the data. So instead of, basically one surgeon being a steward of that time, you basically have 6 surgeons assigned to a block, and no one really owns it. Everybody kind of halfway owns it. So it makes it a little bit difficult. So the first step for us, as you can see here, was basically transitioning from service lines blocks to individual blocks. So what we did was when we were coming out of the pandemic and the hurricane, we had basically sort of assigned some service line blocks, and I went to each individual chairman and said, let me know which surgeons are going to operate which blocks, and we got individual blocks assigned for the most part. There were some service lines that's a challenge for. So for us, service lines like neurosurgery and vascular surgery thought that it would be a lot easier for them, just from a practical point of view, to keep sort of a group block. So we did do that for some service lines, but the vast majority of our blocks now are assigned to individual surgeons. So again, as I said, what this does is it really increases the accountability of the surgeon for that block time, makes them good stewards of their time. And it also gives us more visibility at the block committee and at the OR leadership level to figure out how this block time is actually being used at a very granular level. So the bottom line is, by doing all of these things and implementing that, the goal is to try to increase OR utilization by managing the block assignments and assigning the blocks to the people who are going to use them the best. The other shift that we made, we used to look at just straight up block utilization. So our old block policy was, if you wanted additional block time, you had to demonstrate that you're using more than 80% of your block. You had to have a block utilization of better than 80%. You had to have out of block utilization on top of that. That doesn't really kind of paint the whole picture, because you can have pretty good block utilization and still have chunks of unused time. So what IQ allows for is, instead of looking specifically at a percentage of block utilization, it looks at what they call collectible time. So it looks at big chunks of time within a assigned block that can potentially be repurposed to people who need more OR time. So it tells us a little bit more of a detailed story of what's going on with that block. And really using this collectible time is how we've moved forward with figuring out what to do with our block assignments. So there's three components to collectible time. So the first component is basically if you have an entire block that you either don't manually release or and that you don't use. So we do allow for manual release of block time. We allow for quote unquote credit for releasing block time up to a certain percentage, and that's one of the components of collectible time. But basically, if your service line has a block that you did not manually release before it auto released and you still didn't use it, that's just technically an ignored block. So ignored blocks count against your collectible time. We also look for continuous pocket of unused time within a block. So let's say Surgeon X has an OR block from 7 a.m. to 7 p.m. and they operate from 7 to 12, and then they don't operate from 12 to 5, and then they operate from 5 to 7. That 5-hour block of time in the middle of that block is collected. Likewise, if you've got a 7 to 7 block and you operate from 7 to 12 and don't use from 12 to 7, that's also collectible time. And then you can set that parameter for whatever you want to set it at. You can make it 5 hours, 3 hours, 4 hours, whatever you think is a usable chunk of time for you in your OR. And then also the third part of this is manual release time above an allowable threshold. So you can say, we're going to allow 50% of your time to be manual release before it starts to count against you, or 30% or whatever percent. So we basically, when we started out, we set our parameters at 3.5 hours for the continuous unused time, and then 50% for the manual release threshold. The other thing that we did was we sort of shifted our robotic scheduling practices to help sort of fit what are recommended best practices. So the whole idea was to try to align the scheduling practice, align the robotic scheduling practices, try to make things more efficient. So we looked at the surgeons who are the highest volume surgeons and tried to prioritize time for them. We've rolled out a new robotic block schedule that aligns with the regular OR block schedule, so people's robotic time lines up with their assigned block time. And what this also does is it allows, visibility to where time's not being used and release of time, and creates open time in the robotic room so that we know that when extra time is being requested, it can be granted and used. We also have used a lot of the tools that IQ has available to sort of drive surgeon engagement. So some of the things that happen are weekly notifications that get sent out to the surgeons via email or via text message if they have the app on their phone, kind of letting them know what their individual statistics are. The OR leadership also gets statistics for the institution as a whole. So we know weekly, what our case volumes were. Is it up or down from last week? Is our utilization up or down from last week? How's our staff room utilization? How's our prime time utilization? So we're able to try to track things week to week. Surgeons get sent reminders. So right now, most of our OR auto release times are at about 7 calendar days for most blocks. And so email reminders get sent out to surgeons, letting them know over the next month or so how many blocks they have available and they want to release them and that sort of thing. The other thing too that we found is that, in the past, people try to get creative with trying to find OR time. So they'll go on Epic and they'll look at the snap board and they'll look for open time somewhere, and then they'll call the scheduling off, say, I want to put this case on for that time. Not realizing that time is showing is available in the snap board, but it may not be available in terms of staffing, or the type of case they want to put on may not be able to be done in that room, or there may be some logistics. So then it puts the OR schedulers kind of in a bind, because now they have to be the gatekeeper of that time and tell people no. So one of the big advantages of IQ is it really sort of serves as a single source of truth for all of the OR metrics, both for the surgeons and for OR leadership and for the surgical schedulers. So it helps to support conversations that are backed by data and helps people to feel more comfortable with the decisions that are being made. So just to kind of share with you some of our key results here. So prior to the launch of IQ here at Ochsner, we really had zero manual release of block time. It was very, very rare that people release block time manually. So the time was not becoming available ahead of time. We have to wait for it to auto release cases, but then get kind of slid in at the last minute where we needed them to. So over the first basically 6 months or so of utilizing IQ, almost 6 months of utilizing IQ here, we've had over 23,000 released hours, and we've got surgeon engagement of 64 of our active surgeons, which is better than 50%, which for surgeon engagement for something like this that basically had it's instituting change, which surgeons don't like change, to get more than half of our surgeons actively involved and engaged is nice. The other thing it's allowed for us is to help improve our OR scheduling predictability. So again, in the old days before IQ, you'd come in the morning and there would be 10 or 12 cases on the pending list, and then we just wait for rooms to open up to slide them into. Well, now, with the manual release of time and being able to find OR time in advance, we're able to more predictably or more reliably predict our OR schedule, predict staffing needs, predict PACU needs, predict bed needs, things like that. So you can see here month to month since we've instituted IQ, we've seen a steady increase in the number of released minutes. And then in the green bars here are basically a steady increase in the number of OR cases being scheduled into those minutes. So, in the first quarter of this year, we were able to get 126 additional cases put in during that release time, which really eases up some of the OR scheduling issues. And that equates to a 28% release fill rate, which is pretty good. It's also allowed us to really kind of ramp up on our prime time utilization when we have the most staff here. We want to get the most cases done when the most people are here. So by implementing this process and being able to sort of streamline the scheduling process, we were able to increase our prime time staffed hours 8% in the first quarter of this year compared to the first quarter of last year. Also, in terms of robotic primetime utilization specifically, we've also been able to show significant increases in that. We've actually increased our robotic utilization in primetime hours 10% in the first quarter this year compared to last year. If you look at overall OR block utilization, it's also increased significantly. Now, granted, we don't necessarily look specifically at the block utilization percentage as sort of the end-all be-all key metric, but it's nice to see those numbers going up, and it also equates to having more collectible time that we can find as well. So that's all I have. I'd be happy to entertain any questions at this point. And again, thank you guys for your attention and kind of hearing our journey here at Ochsner with implementing IQ and hearing about some of the successes that we've had.
Thank you, Dr. Can. We'll now use this time to answer any questions you may have for us. Please enter them in the Q&A box below. We'll try to get to as many as we can. What strategic approaches can surgeons employ to effectively garner support and acceptance from physicians and providers when integrating new technology?
So, as I said earlier, surgeons are reluctant to change. So, trying to convince a large group of surgeons to embrace a new technology and embrace a new methodology of doing something is definitely a challenge. I think the advantage that we had in this situation was that our prior system was so broken that people were hungry for something to try to improve things. So I think sort of leveraging that can be a big advantage. I think the other thing you can do to sort of leverage engagement is to really be very transparent and be very open and honest with what you're looking at and what you're trying to accomplish and what you have accomplished. And I think that as we rolled this out and we showed people the data and we saw the increase in staff utilization, the increase in collectible time, the increase in booking cases into those times that were released, people, as they began to believe it more, they became more engaged, and by word of mouth, it spread. So initially, it was like a handful of surgeons who were requesting all of the open time. And as word got out, people, more and more surgeons started asking for time, and it was sort of like a steamroller. I mean, things were rolling downhill like a snowball, and it just kind of kept picking up speed and kept picking up speed. So I think the big thing is just being open and honest and transparent about what's going on, and making sure people have access to the data. That's the other really nice thing that about the system, is that surgeons can log on. It's a web-based system, so it's not like you need to have access to some special website and have special. You just log on to the website, you log in. It's a single sign-on type thing with our intranet system, and you get immediate access to the data. So giving people access to the data helps a lot, and showing that we're actually accomplishing what we hope to accomplish helps.
From a patient's perspective, what impact do you think this tool has on their overall patient experience? Most of what I do, I'll speak from my own personal experience, is I do mostly colon cancer surgery and surgery for inflammatory bowel disease. So you have someone coming into the office, they've just been told a week ago they have colon cancer, they're anxious, they want it out yesterday. And for me to come in and talk to them about surgery and kind of get everything rolling and say, okay, well, I'm going to have to look for some OR time, and we'll call you back next week when we can figure out when we get this done. That just sends them out of the office. They're already in a downward spiral, and they're spiraling even more. So to be able to say, all right, we can get your surgery done next Tuesday at 10 o'clock in the morning, it gives them something to look forward to. And so it definitely improves the experience for the patient in that regard. They're not waiting around for their OR time. Most of the time, we can give them a date and a time on the spot. Every once in a while, if my time's full and I'm requesting open time, I'll let them know, hey, there's some time on Tuesday, I'm going to request it. Most of the time we get it. As soon as I know, we'll let you know. But if not, let's look at a couple of our options. So when they leave, they know it's either going to be one of 2 or 3 dates that we give them. So it's overall a patient pleaser for sure. Just being able to expedite their surgery. Have your clinic schedulers provided positive feedback on the tool's impact on workflow efficiencies and their ability to schedule cases more efficiently in the OR?
Yeah, no doubt. I mean, the way we do scheduling here at Ochsner is a little bit different. It's sort of a mishmash of scheduling practices. Some groups, like my department, we do all of our own scheduling, which is nice because we like to have control over our schedules, so we know what cases are being done which day. Other departments they put it in a depot, and it goes to their schedulers, and their schedulers get everything on the schedule. So it makes it a little bit more of a challenge for them, but if we have control over our own schedule, it makes it a lot more efficient in terms of being able to find time and get things put on, where we want to get them, which is very nice.
Thank you, Dr. Can. Thank you all for joining us today. We appreciate your great questions and engagement during the session. We would also like to thank our speaker for taking the time to chat with us. As a reminder, please check out the resources section in your console and complete the survey. Have a great day.